Welcome to our ICMDA COVID seminar. I'm Dr. Peter Saunders, the CEO of the International Christian Medical and Dental Association, and this is the 8th of our series of seminars. And today we've got Dr. Bobby John speaking on flattening the curve and prevention in low resource settings. Let me introduce Dr. Bobby John. Dr. John is the Managing Director of Aquitas Consulting, providing health and development-focused advisory and consulting services. And he formerly left a medical career with the Indian Army to work with Pandita Ramabai Mukti Mission. And besides serving on staff at the Church of North India run Wadia Hospital, World Vision India and the Gates Foundation, he has board leadership roles at the Global Fund to Fight AIDS, TB and Malaria, the Emmanuel Hospital Association, and currently leads Aquitas Consulting, as I said. He's also co-founded Global Health Advocates, the Integrated Health and Wellbeing Council, iHeal Innovations, as well as the Journal of Development Policy and Practice. So he is eminently well suited to speak on this issue, and we're delighted and very privileged to have him today. So welcome, Dr. John, and I'll hand over to you at this point. Thank you.
Thank you, Dr. Peter Saunders. It's my privilege to be here with you. Thank you for asking me to share from what I understand of what's happening around the world. My particular gratitude to the ICMDA Fellowship and also to Dr. Santosh Matthews, who facilitated my appearance this afternoon at this webinar. For all the things that Dr. Peter Saunders very kindly did by way of introduction, I know that he is as confused as I am as to what I really do. Part of my job is to try and make sense both internally and externally, the kinds of things that are happening around, and then see if they all align to any kind of pattern and if there's any insight and wisdom in which we need to walk and act on. It's in that spirit that I share both my thoughts and this presentation with you, and I hope that we will have a useful time of interacting with each other as I complete my slides. The presentation is titled Flattening the Curve in Low Resource Settings. On your screens, you also had the word prevention, and in an act of deliberation, I have dropped the word prevention, and I'll come to it very soon as to why that word does not appear in any of my slides. Over the last 90 days or so, flattening the curve has become a mantra of sorts. It was something that was not unknown to those that had trained or have formal training in epidemiology, but it became popular, and the general and the specialist press ran with the phrase, flattening the curve. And essentially, many variants of the slide that is in front of you is what people have become incredibly familiar with. They know that there are two curves, one peaking early on, another one slightly down the time axis, lower. Others have helpfully put in another dotted line, basically saying below this is flattening, above this is not flattening. Our job this afternoon is to understand what it means to flatten and what are we trying to flatten for ourselves, because this is no longer a single community, a single nation issue, but it's a global issue. The word pandemic and the pandemic declaration, which came on the 11th of March, indicated that we were all in this together. So it doesn't matter whether you are listening to me in the Portuguese translation or in the Russian translation, or you're just waking up on the western part of the world, or just about to tuck in on the eastern part of the world. We are all together confronting a reality of a pandemic. When the clarion call went out that there was a pandemic and the curve needed to be flattened, what was it that was being meant and who was it being addressed to? By my understanding, the virus is illiterate. It doesn't take any notice of whatever we put out by way of declarations or by way of notices. It would continue to do what it had to do, which is to move from individual to individual, aided by individual behavior. So wherever people moved, the probability of the disease transmission was very high. So then who was flattening the curve, the message intended for? It was intended, to my mind, to two audiences. One, for the general population, essentially to tell them that if they stopped moving around too much, if they stopped the frequency of their interactions, if they socially distance themselves, that's the other phrase that's caught on like wildfire, then the probability of this, the rate of spread would come down. The second intended audience for this flattening the curve message was for those that were tasked with building up healthcare capacity. Knowing that this was a rapidly spreading disease, knowing that it had an R0 that was definitely not 1, and there were estimations that this could be as high as approximating measles, and truth lies somewhere in between. We still aren't very, very sure where the R0 lies. Those that were tasked with the building up of healthcare capacity knew that they needed this time, this flattening time, to be able to build the necessary capacity for the health system to address the oncoming numbers of people that would be sick. As we go forward with our webinar this afternoon, I would like to address what this flattening means, who did the flattening or what needed to be flattened, and where are we at. While we've had the COVID epidemic, we've also had another epidemic at play. Anybody with basic math skills and a graphing software essentially began producing these kinds of graphs, susceptibles, infected, removed kind of graphs. And essentially we had a rush of models by the first week of March. So we had a COVID transmission epidemic, and we had a mathematical model epidemic that has put many a government in difficult situations. If they have accepted one set of models, others have basically said they are wrong. If they have not gone by a particular model or one influential group, then they have run the risk of annoying others. All the while, most people forgot that models are just models. They are not absolute. They tell you a directionality, and so long as there's a directionality that is being observed, that's all that matters. But those that did not want to take a model would essentially proclaim the numbers haven't come true, the expected numbers of deaths haven't happened, or vice versa. And so therefore, we've had the debate between modelers and models to the great detriment of populations in countries and subnational jurisdictions. And that is something I hope we will take as a lesson for the future, that while models are great, we need to be careful, and policymakers need to be a lot more understanding of the benefits and limits of modeling exercises. Essentially, what was the message that was coming through? In the absence of any established therapeutics, in the absence of an effective vaccine, and how could it be? It was a novel coronavirus. It hadn't been seen before. The thing that everybody was depending on were non-pharmaceutical interventions. Wash your hands, distance yourself physically, disinfect, separate people out. Those that seem to be looking like being infected, isolate or quarantine, and reduce the rate of growth of new infections. In doing so, you would reduce the day-by-day increase in active cases. And hopefully, while that number was being spread out over time, you would be able to utilize the window that was being made available to increase the capacity in countries. And this is where I want to kind of put one of my first asterisk points. The ability to flatten a curve depends on the presence of a good surveillance system. Our talk is titled In Low Resource Settings. Most countries have some form of surveillance systems, but the sensitivity with which they pick up new or novel infections is widely variable. And so the expectation that a low resource setting would pick up an early case and be able to isolate it is something that seems to me as a conundrum. Even in the case of countries with great resources, we have found them singularly lacking in their ability to pick up cases very early on. And even where there have been alerts in certain jurisdictions, systems have chosen to ignore those alerts for political or administrative reasons. A successfully flattened curve would spread the number of cases over time, allowing for the buildup of capacity. If the assumption was that there would be 100,000 new cases, sick people coming in, and your available beds were only to the order of, say, several thousand, then one would take the time that was bought from the flattening efforts to be able to establish new facilities, or at least ramp up the capabilities within existing ones, so that when sick people, the deluge of sick people came in, you would be able to manage them well. As we will see, the curves that needed to be flattened were not just one, but several. What we almost all took for granted was a flattening of the curve would be just the active cases curve. The number of people getting infected, could they be reduced down in time? Could we spread out people? Could we have shelter in home? Could we have quarantines? Could we have lockdowns? All in an effort to slow down the transmission of the disease from those that had already contracted it to those that had been in their close proximity or had the probability of getting infected. Unfortunately, most jurisdictions took their eyes off the collateral damages that were associated with COVID-19. Everybody was focused on the comorbidities, diabetes, hypertension, renal disease, cardiovascular diseases, and thought about the probability of those people getting more sick. But some things that got wildly underestimated and ignored in many jurisdictions were basic things like hunger, inequality, mental health, and fundamental barriers to healthcare access. All of these are also inequality curves that needed to be flattened. Working in tandem, these collateral pathologies or damages have made COVID-19 a far greater issue, a far greater humanitarian crisis than we had anticipated at the beginning of February or March this year. Let me take the first one. To flatten the curve, we've had two competing visions. One led by this whole mantra, test, trace, isolate, treat. Now, different places have had different ways of formulating it. Some have said trace, test, isolate, treat. Some have dropped the word treat. Some have said isolate first, trace. Whichever way these four words have come in, they together form a vision that is built on the capacity to test people for the presence of the COVID-19 coronavirus, which meant that there would be capacity in countries to be able to administer an RT-PCR-based test, which in low resource settings were hard to come by. even in very high resource settings, the ramp up of testing facilities was slow or reluctant. The costs were high. And the question was, even if we tested people and knew that they were positive, what were we going to do? Couldn't we just let this become an epidemic that runs through the community and gets us to herd immunity? I'm not going to get into that debate. But this vision of testing, tracing, isolation, and treatment predicates that there would be resources. And in low resource settings, this became an impossible task. Even in countries like India, which had a well-functioning laboratory network, the ability to scale up tests commensurate to the population size, commensurate to the exposed population size, or the anticipated need of testing has been way below expectations. The costing for tests, both in terms of the physical hardware, in terms of the kits, in terms of the personnel, in terms of the laboratory capacity physically, have all been far greater than what had been anticipated any other time before. The WHO put out the mantra, test, test, test. Well, we are where we are. And at this point in time, in a subsequent slide, I will point out the kinds of tests that are available and the utility or the futility of employing any or all of them. But understanding that the ability to test was entirely dependent on the resources available in the country was something that we did not adequately pay attention to. And therefore, nearly 180 days into this pandemic, we will see a vast divide between countries that have the capability to test and the countries that had it but did not, simply because the economics did not make sense to some people. Even if you tested people positive, would you go around, did you have the capacity to trace those that were primary and secondary contacts? That's a whole other ball game. One can be done in the lab, but doing things beyond in the community requires a level of training and a level of human resources that most low resource countries haven't invested in. Isolation, whether it would be at home or whether people who were tested positive would be sent to hospitals, would that be a good strategy? And we see from multiple jurisdictions that sending people into hospitals only amplified the explosion or the increase in infectivity in those healthcare settings. Would there be a place for centralized quarantines or separate facilities other than the regular hospitals where people could be isolated? Would that be a strategy for low resource settings, which could be easier done? Is something that we need to debate about. And the jury is still out there. Perhaps in my mind, a little bit in favor of the need or the necessity or the utility for centralized quarantine, where large numbers of suspected positive people can be put together rather than being put into hospitals where there are sick people already and displacing the regular sick people from their care that they need. And the last bit is treatment. When people fall very sick, they deserve the treatment that their condition demands. In most low resource settings, the ability to put somebody on a high flow oxygen or to institute newer therapies, or in late cases, to put them on advanced life support systems has been severely constrained. Is this going to be an accentuation of the great resource divide between countries that have got the resources and countries that don't have it? It's interesting also to point out that countries with resources like the United States have seen such a large mortality number. I would leave that as a standalone observation, because that is something that we will need to come back to at some point to understand what does resource availability mean, low or high, never mind. There are limits to testing, as the Philippines flyer puts it out. there is inadequate laboratory capacity. We've just talked about it. They were able to do only 8,000 tests per day for a population of 110 million Filipinos. The other one, which talks about India, for a population base of 1.37 billion, that's 2.3 million test samples done. That's as of 18th of May today. Are they adequate? Certainly not. Should we amplify the number of tests being done? Logic says yes, we should. If we need to, then how do we go about increasing the number of tests? And this is where this menu card literally unfolds out. There are molecular tests, there are antibody tests, there are antigen tests. Are all of them appropriate? Perhaps not. Is there a way to bring down costs on the molecular tests? Is there a way that we can reimagine testing strategies? Should we be looking at pool samples? Should we be looking at a kit preparation such a way that regular PCRs in university labs could run more tests, thereby increasing the number of tests per day that's available in countries? Those are all strategies that are worth thinking about, because trying to put in high throughput machines in low resource settings runs up against two difficulties. One is the cost of acquiring those machines and setting them up. And second, the near impossibility of gathering between 300 and 700 samples at a time and transporting them in biosafe environments to be able to run them in a single batch. Is there a point in thinking about breaking down these tests into its components such that they can be run more easily in peripheral hospitals? Is there a way that we can reimagine the sample collection so that they are biosafe? Is there a way that we can think in terms of simpler, cheaper kits that render the sample to be prepared for running on regular PCRs? Those are all options that I don't think have been adequately explored, particularly for low resource settings. We are still taking the model from high resource settings and thinking in terms of the state-of-the-art machines running 96 tests or 324 tests or 700 plus tests at a time. They may not work. And that is a challenge that we need to do. The temptation is to go towards the antibody tests, especially with the ease of doing and for the costs. I would caution us to not go that way because they don't enable us to get to an earlier understanding of where the true spread, where the transmission of the disease is. It may tell us where the disease has spread, but it doesn't tell us where it's actively moving right now. And so therefore, there would be a caution that I would sound there. The other competing vision from test, treat, trace, and isolate is lockdown, 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 lockdown. As I speak, India enters a fourth phase of its lockdown and will be in lockdown for another 20 days or so. Lockdowns as a strategy, as a blunt tool to enable the building up of health capacity is worthwhile. But when it is not accompanied by the buildup or the investments into either building up beds or supplies or strategies to enable people to be in isolation, then we end up riding a tiger which is very hard to get off, as is being seen in many jurisdictions. Lockdowns, once initiated, are a blunt tool that are very hard to get off. And then it leads to that inevitable public conversation, let's get the economy running because people are going hungry or people are going jobless. The economy is bleeding. The cure is worse than the disease. In fact, this newspaper clip that I have right now does show this sidebar which says experts COVID-19 curve shows no signs of flattening. And this is with 3 phases of lockdown in India already down. And that kind of is the other vision that has been there. And in low resource settings, this seems to be the easiest thing to do and with very little costs attached upfront. But the larger costs that are exacted on the economy and on individual well-being are far too greater than what we have tabulated so far. And I would again think that it would be incredibly important for policymakers and governments to be thinking very carefully before instituting countrywide lockdowns. We've seen this particularly from India, and I suspect from other parts of the world, we will see more pictures coming through. That as lockdowns were initiated as a low-cost strategy, without adequate social support, hunger began mounting. As it is, our communities have been food insecure. With lockdowns in place, with supply chains literally coming to a standstill, millions of people have been pushed over into absolute food insecure situations. Where we have made gains over the last decade or so in building up nutrition status across communities in Africa, in Asia, in other parts of the world, we seem to be losing that very rapidly with this enforced lockdown or supply chain disruptions. And this is something that we need to be mindful of. This is a curve that we will pay very, very heavily for, because this is not just one generation, this is also intergenerational. And that is something that we need to be mindful of, another curve that we need to flatten out. Those that have been pushed into food insecurity is one part of the story. We also know, and the paper on the left-hand side points to it, that people, not just with comorbidities, but also those with low nutrition status, also were more predisposed towards COVID-19 infections and bad outcomes. And that's where we need to be mindful that, especially among our elderly, that we are figuring out ways and strategies to be able to support them lest they fall sick. It's not just food insecurity. With lockdowns, with shelter in place, with economic activity stopping down, with most people not having jobs anymore, the inequality curve gets to be even more sharper. It is estimated that we will have at least a percentage point drop over global GDPs. India is estimated to have a zero growth rate in 2021. This means large numbers of people are going to not only have no jobs, but they will also have bills to pay. And when they run out of whatever savings they have, they will be left looking for either charity or other means to support themselves. That leads us into a very difficult situation in the rest of the year as it lies ahead. If you look at the graph on the left-hand side, stacked, simply reflecting the share of its population as India in the losses in labor productivity, in total factor productivity, in in trade restriction scenario, and it continues across almost all jurisdictions in the low and middle income countries. If the headline basically says that we will see a dramatic exacerbation of poverty and food insecurity as COVID-19 ravages through parts of Asia and Africa and Latin America in the later half of this year. Most of these are low resource settings. As it is, the resilience of the systems there were suspect. With a shock like this coming on, with upfront expenditures required for the health systems, what happens to the broader economy, what happens to the broader food systems, what happens to the broader social security and social net is something that's more than worrying at this point in time. With so much of stress, we have to be mindful that people are going to have things going on in their heads. These are extremely stressful times. We cannot think about health only in the physical. The mental health graph is rising, and it will overwhelm not just individuals, but communities. One of the things that's being said is that we will emerge on the other side of COVID-19 with a global PTSD epidemic. Whichever way you want to use that terminology, we have a situation that needs to be dealt with in the here and now. The instances of people who are forced into shelter in place or in lockdowns and suffering abuse, whether it is within marriages or children or substance or just wanton violence, all of these will have to be addressed and need to be addressed. And these are not liable to laboratory tests. These require outreach into the community and hands and feet that will reach out into the homes, especially when we are being told to maintain physical distance. We can say the government must take care of mental health of people. Governments cannot do that. Governments can only enable those that have the willingness to step out to be able to care for others. We can tell everybody to stay and remain positive, but who spreads the message of positivity? Who lends a shoulder that people can put their head on, especially in these times of physical distancing? These seem to be conundrums that need to be addressed, because the mental health, ill health epidemic that we are right now confronting ourselves with will balloon out. That curve needs to be flattened, and we need people who will step out and be available for the conversations, the caring conversations that are so desperately needed. All of this basically tells us that now, notwithstanding whatever resource levels you were starting off with, whether you were in the United States or whether you were in Italy or whether you're in Algeria or whether you're in Bangladesh or whether you're in Papua New Guinea, it doesn't matter. In the face of COVID, in the face of this enormous surge, all resources look puny. If I look at the WHO Strategic Preparedness Response Plan and level 5 to level 1 being the least, I see a clustering of most countries in level 3, especially the populous ones. And that to me is also a political balancing act. Most countries do not want to be shown up for having been less prepared or having less preparedness. In all honesty, the inequalities, the economic inequalities reflect very, very clearly in the access to healthcare in almost all these jurisdictions. Those that are able to buy healthcare for themselves, we see the travesty of them buying ventilators for themselves. For those that can't buy a meal, they don't even get counted in the funerals that are being conducted in many, many countries. Enabling access to healthcare is a fine mantra. 40 years ago, we said health for all. We haven't come anywhere near that vision. We came to a reformulation of that with universal healthcare. I see conversations as the World Health Assembly starts today. It's already started. People saying that UHC will solve this whole healthcare access issue and will impact COVID. I think it's the chicken and egg conversation that people are having. There is no substitute for focusing on the well-being of human beings, the well-being of communities, and the investments that are needed for enabling that well-being haven't been made and need to be called out. Like HIV a couple of decades ago, COVID right now calls out the enormous barriers to healthcare access that are present in our communities. That inequality graph grows and that needs to be flattened out. Does that mean more resources? Does that mean more concessional lending from the World Bank, IDA, and the IMF groups? Does that mean that there will be more donor conferences like the one that the EU hosted a couple of weeks ago? Those and much more. There needs to be reprioritization within the countries for where the health of the people will matter. And we haven't seen that shift. I hope that COVID provides the necessary jolt for countries to be able to do what's required. There are further inequalities that are coming. Piggybacking on new technologies, People are already saying that COVID pandemic will reshape how healthcare is done. Everybody likes a silver bullet. But what I see is a further worsening of the divide based on access to technologies. For those for whom electricity is hardly available for more than a few hours a day, the promise of internet connected devices and regular monitoring and updation is a mirage. It may work in some jurisdictions, but in low resource settings, that will not work. When newer modalities come in and the arguments are already on, who gets first rights to a vaccine as and when it comes? Even if it doesn't cost more than, say, 25 or $30 billion to vaccinate every human being on the planet as and when such a vaccine comes, the question will be who gets first dibs on it? Will that be preferentially given to those that are very vulnerable? Will it be equitably distributed across the planet? Or is it going to be something that is going to be cornered by those with the ability to pay cash on the barrel? And that is where the conversation will need to be had with the low resource jurisdictions at the same table as those with the money bags. We should not come to a situation where we do have an effective vaccine or we have a set of therapeutics that are now distributed based on the ability to pay and not on the equity and the equality of all human beings. Which brings me back to the last slide. So where are we as Christians? Because this is, after all, an ICMDA webinar. This month, the National Council of Churches Review did have a couple of articles put out together, talking about in the midst of death, there is life. The church and the COVID pandemic in India, COVID-19 and life after. Those are good starts. The ICMDA, the Church Universal, the mission organizations, the health and medical missions all need to be seen in the middle. I have taken this part of the slide from an earlier presentation that you had seen from Dr. Santosh Matthews. There is us talking about containing the epidemic. There is them at the community level who are thinking about protecting themselves. Both sides have valid desires, but truth, I think, lies somewhere in the middle. Bridging this gap, making the interventions that make sense available at the community level, bridging the needs of the community with the resources that can be made available, advocating for strategies that make sense rather than those that are driven by agendas, use of technologies that are accessible and understandable by the community, demonstrating the value of interventions that have the potential to change the trajectory of sickness in the community. Those are roles that the people of God, that Christians, healthcare workers, motivated by the love of Christ, can and should do. The space for many such interventions is shrinking in many jurisdictions. But in times of difficulty, nobody turns away a good intervention. If we can put together our best thinking, if we can demonstrate that each of these curves can be flattened, need to be flattened, and can be addressed at the community level and have got additive effects on overall flattening the COVID-19 curve, we would have done a good job. If we do those, we come to the word prevention. Because at the end of the day, if we have enabled the flattening of the curve, as we started off, the number of cases over time, if we can reduce that and spread it out, and if we are able to address the collateral pathologies or difficulties in the community, we would have prevented a lot many more people to be in positions of vulnerability and of falling sick, and dangerously so. Prevention would be an outcome, not a starting point of all our efforts. And with that, I turn this over to Dr. Peter Saunders.
Thank you very much, Dr. John. Well, that was extremely enlightening account of all the curves, not that of active cases alone. So if we go to the questions now, Dr. John, the first question we've got here is making the point that some countries have done much better than others, and that some low resource countries have done well. So according to your knowledge so far, could you mention what countries categorized as low resource settings that have been more successful in managing COVID-19, and how can we model their approaches? Are there specific lessons that we can learn from these best practice models?
I see the countries being listed out: Laos, Cambodia, Myanmar, East Timor, considered low resource. To my understanding, and it's still, let me put that as a caveat, it's only 180 days. So with that caveat in place, the only low resource place that I would think of as being exemplar would be Vietnam, some country that is not listed in this question. For all the other countries, my simple thinking is this: that absence of evidence is not evidence of absence. At this point in time, almost all these countries have low resources by way of testing capacity and their healthcare system resilience, and therefore low reporting may actually be an artifact of that rather than an example of a well-managed response. Vietnam, because of its earlier exposure and because of its centralized command control system, is the only place that I can think of within that basket of low resource settings that have been able to manage it well. The other countries in Southeast Asia, whether it is Singapore or separately down Taiwan or further up in Korea and Japan, are all well-resourced settings.
What's been Vietnam's secret? What's been the reason for their success, do you think, compared with others?
It's almost like antigen-antibody reactions. They had been stung by SARS before. They knew how difficult the situation would be. And so there was a systemic memory that kicked in almost immediately. The moment the first cases were reported, their system swung into action. And plus, being a centralized command control system, they were able to institute very strong quarantine measures at the population level, allowing for very good testing and contact tracing and isolation strategies. And so therefore, their actions were when there were 2-digit number cases, not 3-digit and 4-digit. And so therefore, they were able to head off their entire response.
Okay. Now, you mentioned that there are a number of high resource countries that have done very well: Taiwan, Hong Kong, Japan, South Korea, New Zealand, Australia. Are there any lessons from those that are applicable in low resource countries, or is it really just a completely different situation?
Almost all of them, again, are uniquely, like I said, antigen-antibody reactions. They have seen either SARS firsthand or have had a second-order impact some 20 years earlier, and have had their systems prepare for such an eventuality. And so therefore, they were able to kick in very, very early.
Now, in terms of playing off the economy versus the health effects of COVID, it's been argued that in majority world countries, like many in Africa, some in Asia, the economic damage will be far greater than the gains from locking down the country. And you've certainly mentioned this. What are your own views on this, and who are the best people to make these very difficult assessments?
The choice to lock down an economy has to be made after a lot of considerations. and it is predicated on only one consideration: the ability to strengthen the healthcare system, however rudimentary it might be. A goal needs to be set that we will increase our beds from X numbers to 10X or 100X, as may be the projection, work towards it as rapidly as possible, and as soon as you're approximating that capacity, open up. Anything other than that is counterproductive. It is lost time. You have not done what is required, which is the increase in the healthcare capacity, and you have strangled the economic activity and the incomes of people. And that is a double whammy at the population level. The economy suffers, and when you open up reluctantly, whenever you do so, you will have a raging epidemic without too many recourses.
Given that testing is so difficult and that the effects of lockdown are so devastating, is there any way that low resource countries can deal better with this? I mean, people have talked about green zoning, walling off people who are more vulnerable, for example, or is it really just about social distancing and hand washing?
To mix diseases, metaphors, whichever way you want to do it. When you have somebody with dengue in the community, what do? You put a mosquito net around the person with dengue, so that that reservoir of infection is not going to be available to the vector, the mosquito, to be able to bite somebody else. And so if I were to take that insight and put it into low resource settings, the recommendation or the imagination that I would have is, if somebody is tested positive or is suspected positive, they are not left alone in that community, that they move to a quarantine facility that's away from their regular settings. Imagine Bombay, Dharavi, or any other urban slum where the per available square feet area for per person is less than, say, 20 square feet, even lesser. And with summers coming along, it's going to be incredibly hard either for people to stay together or to be not staying together. Both ways, you have to take people out, those that are suspected or tested positive. They need to be in facilities where they're taken care of, stabilized, and then allowed to come back into the community or moved on to a higher care facility. If we have not built those capacities, that's the lowest cost strategy that I think is available for mitigation of the spread of the disease.
And would that include people with milder forms of the disease?
Yes.
Yeah. So who weren't necessarily needing any hospital treatment?
I would think about airport hangars. I would think about large football fields. I would think of all of those being converted into reasonably comfortable with good sanitation facilities, and enhancing the humaneness of that entire facility, respectful of people's privacy, such facilities to be made. And those would be far cheaper than sending individuals into hospitals where they will amplify the disease among healthcare workers, who are anyways a scarce resource, or back into the community where it spreads.
Just on testing, the people might even ask, well, given that testing is so expensive, so difficult to roll out for such large populations, is there any point of testing at all in low resource settings, given that you might also have to repeat it again later with people? And if so, who should be
There is always a point to testing. We're kind of debating the wrong thing. The thing to be debated is the cost of testing and making it something that's more usable. Right now, the way we're imagining the testing is incredibly complicated, incredibly technology centric, and resource intensive. There is no reason why we cannot split the whole testing paradigm into 3 distinct boxes: the collection of samples and rendering them safe, the kits that could be reimagined and brought down by way of cost, by doing it slightly differently, and I don't want to get into the molecular biology of it, and then running it on generic systems that are available in university labs, not just necessarily in the BSL 2 or 3 labs. And in doing so, you can increase the total availability of testing in any country. If you were to recruit all the universities, suddenly you have a 3-fold or a 4-fold rise in the available capacity than just looking at the tertiary care hospitals. And that's where I would imagine a WHO, all the technical agencies actually putting solid money behind to say, how do we bring the entire gamut of testing into the low cost category? Low cost not being cheap or useless, but low cost in terms of it being inexpensive but valuable.
With regard to Vietnam, and you mentioned this was a centrally controlled economy, are you suggesting that centrally controlled economies, in other words, communist countries, may perform better than democratic countries when it comes to COVID-19?
The only two places that I can point out are probably Vietnam and Cuba. Everybody else, I kind of reserve my opinion on that one. And that's only because both of them have, one, Cuba has had a historical strength in health and a focus there, and Vietnam because the way they've been able to respond to it. Otherwise, it's not a broad generalization, as Russia's numbers will tell us.
I guess people might point to China, depending on how reliable the stats we're getting are, but they seem to get on top of it very quickly with a command control approach.
I wouldn't conflate communism with a command control approach. They may be overlaying each other fairly neatly. I would probably say two things very carefully. One is their ability to do a command control style operation, and second, also the ability to manage their numbers as it comes out in the public domain.
Now, someone here has quoted the Nobel Prize winner Michael Levitt, who said that Australia made a huge mistake with lockdown for massively damaging its economy and society without obtaining immunity to COVID-19, and that the only hope will be a vaccine. And I guess this is a question in many high-resource countries, that if we somehow manage to stop the spread, are we simply delaying the evil day because most of the population still has no immunity, and that it will simply go through them eventually in time?
We will. This virus is illiterate. It does not pay attention to any of our orders. And we have no experience of it as humanity. It will run through our population. And so figuring the optimal balance between what is ensuring safety and allowing for regular life to go on is a matter that will be not just for the healthcare workers to do, but also for sociologists, anthropologists, and all the others who need to work together.
Now, you mentioned about the lockdown. There's only a point of it if you use that time to increase the health system's capacity for testing, tracing, treating, or whatever. What principles would you apply in deciding how long a country should stay in lockdown? This is something that many of the high-resource countries are now battling with.
If your ambition was 10x the start point baseline of healthcare facilities, either by way of, if you're counting by way of beds or the number of throughputs or personnel, or whichever way you want to kind of put that number there, whatever that number is, if you're directionally going that way, and if you're halfway through, begin easing out, because the momentum of building up actually allows you to complete the scale up of healthcare facilities. The more you delay, the worse you will have it when it's almost like a pressure cooker opening up. And then you also have the unintended consequences of the lockdown, both on mental health and also on the economic security of people. And mental health is not talked about at all. Irrespective of 1 day or 5 days or 50 days, that's going to be something that we'll have to reckon with. And we have no tools right now, I think, to manage that.
Sure. Well, we had a webinar on mental health consequences of COVID-19 here at ICMDA, so maybe that was a really important priority, I think. Just a final question now, because we're almost out of time. But do you think there is much likelihood of civil unrest, nationalism, and so on rising across the world as a result of this? People seem to have been very patient so far in what we've observed.
We have seen the raising up of the walls. It preceded, in many jurisdictions, the COVID-19 crisis, but that's the arrival of COVID has actually made the subtle raising up of walls de facto. This is the first time that you're beginning to see countries essentially getting the buy for closing down their borders. Never have we seen that happen. Does that conflict with nationalistic approaches in countries, in certain jurisdictions? Absolutely, and it will be used as an excuse, and that is something that we need to be aware of. Does that predicate unrest? The unrest will not be because of the nationalism, but it will be simply because of the hardship. There's only so long that people will remain hungry or will be able to stay behind locked doors in larger interests. As children go hungry, as violence in homes begin to get unbearable, as reserves and livelihoods disappear, people will start coming out, and it will not be amenable to law and order enforcement. In fact, one of the significant mistakes that most jurisdictions in lockdowns are making is the use of law enforcement machineries to do a public health function that is not their core competence, and it has been applied very, very unkindly to great detriment down the line. This is a memory that people will not forget, and should unrest ever start off, it might be pretty difficult.
Well, I'm afraid that that's all we've got time for today, and the questions are still flowing. Dr. John, we're incredibly grateful for you, not just for your talk, but for the question time where you opened up a whole lot of other issues and spoke some real common sense. And I've personally learned a lot from this webinar. So thank you very much again, Dr. John, and
thank you.
All the best. Keep promoting and speaking the message. It's been most helpful. Thank you.
Thank you.